today I will talk about this sulcus fixated IOL, that what is the indication, when to place. So as you all know that in the bag placement of IOL is ideal. However, in certain situations, sulcus fixated IOL is mandatory or required. So indication for sulcus fixated IOL is posterior capsule rupture, journal dialysis or dehiscence, and aphakia with adequate sulcus support, and secondary IOL implantation, like sometimes post-trauma where we are just doing like corneal tear repair and lens matter aspiration and keeping the patient aphakic with a good support. And pediatric cataract also, many we are getting pediatric cataract with a good 360-degree support. So in that type of cases, we can go for secondary IOL placement. And sometimes, as madam showed, that there is some PCR is there, or there is dislocation, three-piece dislocated. So that cases you can bring that IOL in the sulcus. So selection of IOL is important, as in a previous talk also madam told that a single piece IOL is not preferred in sulcus because of bulky haptic causes more iris this one rubbing and dispersion of pigments. So three-piece foldable IOL or single-piece IOL is preferred for sulcus placement because thin flexible haptic and slightly posterior angulation to reduce iris touch, and it reduces round edge optic, reduces iris chaffing also. So when we are planning to place IOL when there is a PCR, so we have to remember this rule of 9. Like if you have planned like 0 to 9 diopter, then there is no need to change the IOL power. But when you are going from 9 to 18 diopter, then you have to subtract 0.5 diopter in your IOL power. From 18 to 27 diopter, you have to subtract 1 diopter. From 27 and above, you have to subtract 1.5 diopter when you are planning for sulcus placement. So as this Navneet also spoke about how to do good vitrectomy. So prerequisite for sulcus placement is do thorough vitrectomy, good vitrectomy. There should not be any vitreous in the anterior chamber, and complete removal of cortical matter. Sometimes you will see that if there is PCR, many people try to just place IOL, but thorough cortical cleanup, lens matter cleanup is very important, because in future you will not get repeated iritis or glaucoma or CME. And you have to verify adequate sulcus support before IOL placement. You have to look for whether 360-degree or more than 270-degree sulcus support is there, where you can safely place the three-piece IOL. And if there is in SICS or any phaco also, if you have large PCR, you have to look for inferior two-third of sulcus support, because most of the time patient will be in a standing position, and inferior support is very, very important in placing a three-piece IOL or any IOL to keep it stable. So in this case, you can see that in SICS there was a large PCR. So how to place three-piece IOL? So you have to aim for sulcus placement. So when you are placing IOL, you can just lift the inferior part of pupil or iris with your leading haptic, so that you are sure that it is going on in the sulcus. If you tilt or you bend like what you are aiming to place in bag, then it will go in the PCR area. So you have to dial it horizontally also instead of dialing it downward. So coming to like in PCR, placing three-piece IOL in phaco cases. So in this case, you can see that you should avoid going through wound assisted. Always make your wound slightly larger so that you can go make your injector in the center of your pupillary margin, and then you start injecting. And always make sure that how the haptic is opening. Sometimes that loading will be slightly different. So, and always support your IOL with spatula below the optic, so that sometimes IOL, this type of three-piece IOL will have tendency to tilt inside or it has tendency to go inside the vitreous cavity. So always support with spatula and go up to the mid of your pupillary margin and then start injecting and see how the haptic is opening, and accordingly you can twist your hand and then it will go in the correct orientation. So sometimes if PCR is round or you have made a posterior uh, capsular axis, then you can just open your IOL in the sulcus or anterior chamber, and then slowly you can glide your haptic inside the bag. So in a PCR like PPC, where you have linear PCR and you have good support on both the side, that you can place your IOL in the bag also in case of PCR. But it should be tried with more experience when you are sure that you will not drop your IOL. So first you open your IOL in the sulcus and then you tuck your both haptic in the bag. And always make sure that with either with help of Coughlin's hook or Iris hooks, you can visualize your sulcus support in much better way. Like in this case, I have used Iris hooks to see the good sulcus support. Like in this case, PCR with rhexis extension was there. So if you blindly place your IOL, sometimes you may land up in IOL drop also. So first you use Iris hooks to retract and see that how you can easily visualize the good sulcus support. Then you can safely place three-piece IOL in the sulcus. Like this case, it was subluxated cataract. So where one side support was good, but around 3 to 4 clock hours, support was not good. So in this case, I have placed one haptic in sulcus and another haptic I have sulcus iris fixated, how it was shown in that previous videos. So you can see that there was a large dialysis, dialysis on this area. This area there was large dialysis. So after rhexis, nucleus was prolapsed with a biomanual technique. I don't know, video is slightly. So in this case, IOL was placed in sulcus, but I was not sure about support on that other side where there was a large dialysis. So I fixated that part to the iris with iris fixation technique. So this is the case where it was pediatric cataract. It was done long back. So there was 360-degree subsulcus support. So in that case, you can uh, just do that synecholysis or synechia release, and then you can place three-piece IOL in the sulcus also. Like in this case, I used a spatula to separate it from iris, and then you can place three-piece IOL as your. So in all these cases where I am placing three-piece IOL, I will slightly extend the wound and I will go in the mid of that pupillary margin, and then I will start injecting over the spatula so that you are sure that it will not drop when you are placing IOL. And always see the orientation of haptic, how it is opening, and then you can slightly twist your hand according to the opening of your haptic. So after placement of three-piece IOL, always make sure that there is no vitreous in anterior chamber. So you can, if in case of PCR, you always stain with triamcinolone acetate to see, look for any that residual vitreous is there, and then you can swipe 360 degree with a spatula to look for any remaining vitreous is there or not. And if vitrectomy is required, you can do vitrectomy. So complication specific to sulcus supported IOL is UGH syndrome, pigment dispersion, cystoid macular edema, decentration or tilt, iris chapping or chronic inflammation, and glaucoma can happen if it is not properly managed or properly placed. So this case you can see what is there in this picture. Any like this lens was flipped. You can see that it is upside down, and it was total optic capture. And this patient presented around 5 days post-op with IOP of 52 mm Hg. And then it was like while placing, that orientation was missed by surgeon and it was placed upside down. And there was 360-degree optic capture. So I have to go for this IOL flipping. So after using dispersive viscoelastic to protect endothelium, first you have to bring that IOL in the anterior chamber, because when you do it in sulcus, sometimes it may flip into vitreous cavity also. So I am bringing that both haptic in anterior chamber, and after using good amount of dispersive viscoelastic, then you can flip the IOL upside down with using two instrument, a spatula and Sinski. Then you can glide your haptic either using Sinski or Kuglen's hook in the sulcus, both haptic. So another complication is decentered IOL. If IOL is not placed properly, sometimes if one haptic goes in beneath this PCR area, then there will be some decentration will be there, and sometimes few patient may complain of glare or shadow. So we have to take this patient for repositioning. So in this case, it was decentered. So I repositioned this IOL. I was with multiple attempts. Again, it was decentering. So I tried capturing it, the optic beneath the PCR area. So you just don't dial it. Just you can dial and reverse capture the optic in the capsular axis margin. So it will become more stable. So take home message, sulcus placement is safe and effective alternative when bag is compromised. Require appropriate selection of IOL and precise technique. Avoid single piece acrylic IOL in the sulcus as it causes more pigment dispersion. Three-piece IOL with optic capture is gold standard for better centration and stability. And as you saw that, always look for orientation of haptic. When you are placing three-piece IOL, it should be in reverse S shaped, so that there will be no, because there will be some angulation in three-piece IOL. So always it will have tendency to come upward and cause optic capture. Thank you.